Pacific University. Oh, I always forget the recording. Thank you. With the Bachelor of Science in Exercise Science, actually. So Gretchen, why don't you take it away and you can let us know what's going on while you're first.
Yeah, thank you so much for everyone for this sort of last minute switch. Unfortunately, I tested positive for COVID over the weekend. And so I am just getting through and hoping that I don't have a bit of a coughing fit through this. But again, thankful for vaccinations, and I appreciate you all for being here. So without further ado, I'll get started. I just want to say good afternoon to everyone. My name is Gretchen Schulz, and I will be presenting on assessing pre-exposure prophylaxis or PrEP awareness and its association with PrEP uptake within 9 sub-Saharan African countries using Google Health Trends and PEPFAR data. For a bit of background, of the 38 million people living with HIV and AIDS globally, 67% of this population resides in sub-Saharan Africa. Additionally, 60% of all new HIV infections occur in sub-Saharan Africa. Pre-exposure prophylaxis, or PrEP, is a medication either in pill form or a new injectable form that is prescribed to persons who are currently HIV negative and at risk of acquiring HIV. Trials for PrEP began in early 2010s and later was endorsed by the WHO as an effective HIV prevention method in 2015. PrEP rollout in sub-Saharan Africa began shortly thereafter in 2016 and has continued to varying degrees in countries with significant HIV prevalence. For this research project, we utilized infodemiology, which is defined as the science of distribution and determinants of information via the internet to inform public health and public policy. Our main data source for this analysis was Google Health Trends, formerly Google Flu Trends, which provides a more granular view of Google searches compared to the public database of Google Trends. Google Health Trends returns data as a weekly relative search volume, which represents the proportion of searches for a specific topic relative to all of the sum of searches for that time and location. With increasing frequency, Google Health Trends has been used to gauge public interest in health topics such as disease outbreaks, epidemics, and most recently, the COVID-19 pandemic. The overarching aim of this research was to assess and describe the trends of PrEP awareness across time in 9 sub-Saharan African countries that have been shown to have the greatest PrEP initiations as of 2019. These countries are South Africa, Kenya, Zimbabwe, Uganda, Zambia, Lesotho, Tanzania, Namibia, and Eswatini. We compiled a list of PrEP-specific and PrEP-related search terms based on common PrEP drug names, PrEP demand generation campaign names and slogans, and related search queries for HIV prevention methods. Each term was run through Google Health Trends individually for each of the 9 countries from 2011 to 2021. This Google Health Trends data was the foundation for our 3 analyses. The 3 objectives for this study were to assess the evidence for increased awareness of PrEP over time, to identify how PrEP-related Google searches compared to PrEP initiation data reported by PEPFAR, and third, to explore the associations between PrEP demand generation campaigns and Google queries. For the first objective, we used quarterly Google counts between 2011 and 2021 per country and ran a Poisson model offsetting the internet data usage and population change over time. After adjusting for the internet usage and population growth, we stratified quarterly Poisson models indicating mixed findings. Orienting you to the graph on the left, you can see a variability in PrEP queries within the countries over the decade. The large Google Health Trends values seen in Eswatini and Lesotho between 2011 and 2013 contained several outliers which differed from the remaining 7 countries of interest. In addition to the 7 of the 9 countries showing a decline in Google searches in 2020 during the COVID-19 pandemic, including Eswatini, Lesotho, South Africa, Tanzania, and Uganda. Looking at the incidence rate ratio table on the right, you see an increase in PrEP awareness as demonstrated by searches in 3 countries, Tanzania, Lesotho, and Namibia, a decrease in 3 countries, Kenya, Uganda, and Zambia, and a null association in 3 countries, South Africa, Eswatini, and Zimbabwe. In general, these analyses show an overall heterogeneity in PrEP awareness, as shown through Google searches during the decade in which we examined, given the ongoing expansion of the internet access across the region. For the second objective, we utilized a correlation or statistical measure of relationship between two variables using quarterly Google counts and PEPFAR PrEP initiation data between 2016 and 2021. The correlation analysis between Google Health Trends and PEPFAR initiation showed a general increase in both variables, but varied between countries. As shown on the left y-axis, we have Google counts shown by the blue columns. And on the right y-axis, we have PEPFAR initiation or PEPFAR PrEP initiations notated by the orange line. Between 2016 and 2021, the correlation resulted in R-square values ranging from 0.02 in Uganda to 0.34 in Namibia. Of these results, only Lesotho showed statistical significance with an R-squared value of 0.11. It is important to note that the different y-axes presented in Lesotho and South Africa compared to the other 7 countries represents a large Google Health Trends data and PEPFAR initiation data. We see, although both Google searches and PrEP initiations increased over time across all these countries, they certainly do not mimic each other in magnitude. The third and final objective, we conducted a descriptive analysis of PrEP demand generation campaigns, visually inspecting the overlap between media campaign implementation dates and Google searches by month to show granularity. Campaign inclusion criteria included only campaigns that were implemented between 2016 and 2021 that had PrEP-specific campaign dissemination materials in the 9 countries of interest, which resulted in 16 campaigns across 5 countries. We compiled the table on the left to show PrEP campaigns per country and their respective timelines. For the visual inspection, we overlap vertical lines depicting the beginning of each PrEP campaign on the graph of Google searches over time. Each line represents the start of the month of the campaign, although 3 of the 5 campaigns in Kenya began in the same month, thus a singular line was used for this time period. Similarly, this analysis shows no strong consistent pattern across the countries explored. However, the graph on the far right, South Africa, Zimbabwe, and Eswatini show a steady increase in Google counts after each campaign rather than an influx in PrEP-related searches that might be expected. Interestingly, in the Kenya graph shows a large increase in Google data between late 2017 and early 2018, which may have been impacted by the Jipende Jiprep campaign beginning in 2016. The graph for Zambia is the only one to display a sizable increase in Google data after the start of the Zambia Ending AIDS campaign in 2019. This analysis project revealed 3 important findings despite heterogeneity in the Google Health Trends data. We saw that PrEP rollout across sub-Saharan Africa did lead to PrEP uptake. However, there continue to be challenges with PrEP persistence. This may be due to challenges in perceived HIV risk, stigma associated with taking PrEP, or difficulty continuing the daily regimen. We also saw that PrEP awareness as measured via Google searches does not mimic the PrEP initiations reported by PEPFAR, one of the largest funders of PrEP promotion. This discrepancy may be due to the limitations in relying on epidemiology data, namely changes in internet usage in the past decade, and that not all people interested or initiating PrEP search for PrEP-related information online. These analyses do confirm the populations in these 9 countries are obtaining PrEP information, but it may not be from the PrEP campaigns or online. Dissemination of information may come from providers, peers, family members, rather than campaigns. In addition, because campaigns are targeting a wide population with a variety of tactics, it is understandable that all persons that seen campaign materials wouldn't query PrEP at the same time. At the bottom of this slide, I noted that future work may want to increase promotion of PrEP and increase the availability of PrEP information online. Populations will undoubtedly continue to use the internet to obtain information. Thus, it is important that PrEP promotion and persistent campaigns increase their online presence. Lastly, this analysis highlights the power of using big data such as Google queries to gauge public interest and inform areas of current public health interventions and a variety of global contexts. Lastly, I would like to thank you all for your attention and acknowledge that, and a special acknowledgement to my first and second readers, Dr. Cherie Schwartz and Dr. Philip Anglovich for their mentorship, the incredible PrEP R01 team for their immense brainpower and support on this project, the TB HIV care team in South Africa for inspiring this work, my amazing cohort members, Kylie for her friendship and guidance, and most importantly, my friends and family and Molly for their unwavering support and love. Thank you so much.
Wonderful job, Gretchen. Thank you so much. So I'm going to open it up to questions, and I'm going to monitor both the chat, so you can feel free to type your question. You can feel free to raise your hand and or unmute yourself. So I'm just going to go with who I see first. And right now I see Haley. So feel free to unmute yourself, Haley.
Yeah, great presentation, Gretchen. I'm so proud of you. You mentioned the power of big data, and I was wondering if you could also speak to maybe some of the challenges you encountered with using Google Trends. I'm just unfamiliar with the data source, but I think that's a creative way to look at PrEP trends.
Yeah, thank you so much, Haley. It was a really challenging data source. It's a private, rather than a public Google Health Trends platform, it's a private API. So we needed to obtain access through an application source to gain access to it, but it does allow for a much more granular view rather than a proportion that you get with the regular Google Trends. Here, or a relative proportion that you get with Google Trends, you get a much more specific proportion of all of the data or all of the searches given a specific time and location designated. One of the limitations is really just the change in internet usage across time, especially as we're looking sort of from this 2011 to 2021. Obviously, the internet has seen quite a gigantic growth in that time period, but also recognizing that not everyone has equal access to the internet and internet sources over these years, and specifically within these countries. I hope that answered your question. If I didn't, please forgive me. My brain is working at partial capacity.
You're doing well.
Okay. Thank you.
Mona.
Yes, hello. First of all, amazing presentation, Gretchen. So proud of you. I love it. One thing that I noticed was that the time frames were not really the same across all of your three analyses. And so I'm wondering, how did you decide on the time frame for each, or what factors played into that?
Yeah, that's a really important question, and thanks for picking up on that. So we wanted to have enough of a time frame to really incorporate the sort of PrEP rollout phase. And so we started to look at, okay, well, if trials were beginning in 2010, we wouldn't really expect to see data until about 2011, 2012. And then with the, so that's where we sort of started. A couple of the limitations with the PEPFAR data was really that they didn't start reporting on PrEP initiates until 2016. And that's why that second analysis using the PEPFAR data didn't start at 2011, but really started in 2016. Similarly with the campaigns, recognizing that PrEP rollout really began at the earliest in 2016, we didn't think that it was appropriate to include campaigns prior to that, recognizing that a lot of it may have been focused on ART or other HIV mechanisms rather than PrEP itself, since that wasn't really rolled out in sub-Saharan Africa until 2016. But thank you so much for that question.
Great. Other questions? David, I see your hand.
Thank you for a great lecture. When we used Google Qualtrics more recently, we were able to get refined data with respect to the number of clicks, its how long on a particular site, how they linked in, and so on. Is that data available to get a more granular understanding of how the site was used?
Yeah, that's a great question. So the Google Health Trends data that we were using wasn't necessarily associated to any particular page. We do have the capability, like you were mentioning, that you can set up Google to start collecting data on a specific page, depending on how people got there in terms of clicks, how long they were on those pages. Because we weren't tying it to any specific website or web page, we didn't collect that data, although it is possible had we decided to, look at a specific PrEP campaign that had been online, et cetera, we could have done that data, but really we were trying to look more at Google searches in general for PrEP preventative methods such as PrEP, rather than like specific web pages themselves.
Yeah. Thank you. Great talk.
Yeah, thanks.
Okay, well, Gretchen, I want to just let you rest and heal now. You did a fabulous job. I would never have known that you were sick. So great job. So
thank you all for bearing with me.
You did fabulous. So another round of applause for you. So now I'd like to introduce our second presenter, and that is Sofia Forneras, and she is one of our MHS online students in maternal and child health. And she is coming to us from Providence College with a Bachelor of Arts in Greek and Roman history, as well as studio arts. So Sofia, if you can share your screen, you are welcome to take the virtual podium.
Yes, let me just. Everybody can see it? Yes.
Looks great. Mm-hmm.
Okay, so good morning, everyone. My name is Sofia Forneras, and I'm going to present to you my literature review on barriers associated with WIC participation and how the COVID-19 related changes impacted the program. I'm going to start with a brief introduction of the Special Supplemental Nutrition Program for Women, Infants, and Children. It's a United States Department of Agricultural funded program that safeguards the health of low-income, pregnant, postpartum, breastfeeding women, infants, and children up to age 5. When it was first instituted, WIC provided vouchers for its participants. In 2010, Congress passed the Healthy Hunger-Free Kids Act, transitioning states from paper vouchers to electronic benefit transfers, which are EBTs. WIC is a short-term program. Infants and children are certified for a year, and most need to be recertified after to continue in the program until age 5. Pregnant women are certified until the baby's born, and they must be recertified after that. If infant is breastfeeding, mother is certified until the baby is 1. If they're not breastfeeding, is for 6 months. Before the COVID-19 pandemic, studies revealed that the most common structural barriers WIC participants faced were due to transportation, childcare, and conflicts relating to taking time off work to attend clinics. This literature review will evaluate whether implementing online services for administrative processes and educational services improves participant satisfaction within the program. The WIC program also, what this literature review is trying to see, that if the remote services can also eliminate existing barriers. Satisfaction is desired in federal programs as it encourages families to seek recertification. This review will first present previously published studies describing structural barriers to WIC enrollment and retention. It will assess the implementation and responsiveness to remote services during the COVID-19 pandemic. And a discussion is presented on the impact of USDA waivers had in improving remote services to WIC enrollment and recertification. So I'm going to talk a little bit about the effects of the COVID-19 pandemic. The COVID-19 pandemic drastically increased food insecurities in the United States. In 2020, the Department of Agriculture indicated that food insecurity in US households with children was at 85.2%. Congress passed the Families Coronavirus Response Act intended to alleviate the impact of the ongoing pandemic. USDA waivers issued remove requirements for physical presence in applications at enrollment and recertification. Before the pandemic, it's important to mention that many WIC programs already started implementing remote services, including apps like WIC Shopper that was created to enable participants to check WIC eligibility of products while shopping. Remote services during the COVID-19 pandemic were extended as social distancing requirements were instituted. WIC adopted online services such as telephone appointments, texting portals, and online education options for its participants. So this study review assessed procedural changes in WIC, including remote application and recertification as a response to the COVID-19 pandemic. It assessed studies that included WIC participation and their perception of the changes that were being implemented, and if those changes were positive or negative, and if they could be seen in the retention rates in the program. Many studies chosen for this literature review focused on primarily Hispanic and African American population. Of the 11 studies chosen, they were divided into 3 areas of interest according to their findings: experiences with participation and retention before or early during the COVID-19 pandemic, WIC changes during the COVID-19 pandemic, and participants' response to those remote services. This is just a chart of the studies that were mentioned during the literature review. So, experiences with participation and retention before and early during the COVID-19 pandemic. Studies like the Neola study that were done in New Jersey urban area use strategies to contacting participants by phone and emailing them easy reminders of their possible upcoming appointments at 1 week and 2 weeks before the scheduled follow-up. Telephone administrative follow-up assessments were also conducted. During those assessments, retention rate was 87%, 70%, and 55% respectively at 2 weeks, 3 months, and 6 months post-intervention. Researchers from that study found that lack of time was something participants mentioned when they were not continuing in the program. The Rosenberg study, for example, found that failure to pick up checks WIC checks was most often related to conflicting work commitments. Women were most likely to report either waiting times for services in WIC clinics were too extensive at 68.6%, or they would have issues taking time off work at 31.6%. WIC changes during the COVID-19 pandemic. The Morris study measured the transition to remote services and expansion of food lists during the COVID-19 pandemic and how it impacted the program's reach and effectiveness. It was found that there was an increase of 5.9% in participation in WIC between December 2019 to December 2020. And the same study found that although WIC participation declined at the beginning of the pandemic, it quickly rose after food lists for WIC participants were expanded. In 2022, we also saw an increase from 78% in 2019 to 96% in completion of nutritional educational services done online. So participants' responsiveness to these remote services in WIC participation in the Wiley study between February and June in LA County, for example, in the year 2020, rates for daily initial certification and recertification increased by 27% and 24% respectively. In the Ventura studies, they concluded that participants were comfortable providing documentation electronically at an 80% acceptance, and participants had positive perceptions of WIC remote services. In the Barnes study, for example, WIC participants expressed relief not being required to attend in-person services, especially during the pandemic when they were scared of getting COVID-19. Before the pandemic, barriers on on-person services have been identified by participants, often resulting in missing appointments. These barriers included financial constraints, transportation costs, and missed compensation due to attending appointments. WIC operating hours usually overlap with an individual's work schedule, making it challenging for a participant to take time off to attend clinics. The bipartisan infrastructure package President Biden signed into law in November 2021 included 65 billion for broadband improvements, which will allow remote services to reach populations that might not be able to benefit from federal programs. The transition to remote services should not be seen as the only option for WIC services, as access to internet is still limited in some parts of the United States. Although modification and service delivery are beneficial to potential and existing participants, some rural areas of the country still lack access to internet. A good idea of how to benefit these people that do not have internet access would be to have mobile clinic services that could be an effective way to reaching isolated areas. Some states already do provide mobile clinic services, like Nashville, for certification and recertification application. So maintaining the USDA waivers for physical presence requirements and providing WIC participants with remote benefits will provide WIC agencies with the ability to reduce missed appointments. It's important that the program should also consider creating training material for WIC agencies on how to properly give virtual services to motivate participants to continue using WIC virtual appointments. Further research is needed to understand the effects of COVID-19 pandemic on WIC breastfeeding practices and WIC online ordering changes. A critical component of WIC is the passionate and attentive clinic workforce it has. It is possible that transitioning from in-person services to remote services may affect retention if participants do not feel personnel is committed to helping them. WIC stakeholders should be encouraged to pursue long-term innovation plans to grow and help diversify the services it provides. The program does need to remain selective and meaningful of in-person services that are conducted for the program. I do want to take a moment to thank Dr. Agustin for all the expertise and guidance and help and support she has given me through this presentation and the paper. And also Dr. Strabino, I'm eternally grateful for the help for both of them, and my family and my team at work for helping me not only form this essay and presentation, but the past 2 years. Thank you.
Great job, Sophia. Wonderful. Again, I will open it up for questions, and just to remind folks that you can either write your questions in the chat or go ahead and raise your hand and unmute yourself. So maybe while we're waiting for a question, I can ask you, Sophia, what do you think are the long-term plans given what you found? Is the WIC program then going to be permanently kind of thinking about maybe more hybrid formats of this?
I think that it's, as the future is going and how everything has changed with the pandemic, I think it makes sense for the program to move certain things virtually, like recertification maybe. But at the same time, during my paper, I do wonder how much can you actually do implement in a remote service without really taking benefit from the in-person services. Right. So I would say yes, but it would have to go with caution.
Mm-hmm. Okay. Susan, I know you probably would have some questions.
Yeah, great presentation, Sophia. I just want to clarify about what's the direction. Actually, the child nutrition reauthorization is supposed to be moving forward, and that's the legislation that governs WIC program. But there's a bunch of what we call marker bills about this very thing, that there are some marker bills that in-person presence waiver should remain, that participants shouldn't need to come in, especially for non-recertification visits. So there is this physical presence question of should we require people for at least once a year come in, and if we can get good participation from physicians to give us the measurements and we can do video calls, that might be something that becomes a virtual. We have the physical presence waiver in place until October right now. So we are currently at the Johns Hopkins WIC program doing everything by telephone. So, and people do appreciate, and sometimes it is easier for a mom to receive nutrition education in a conversation on the telephone and not have to worry to bring their children in or just disrupt their day more. But great job, Sophia. One question. At the very beginning, you had a couple studies that were before the pandemic, like a number of years before, about barriers, and they were talking about checks. And I was wondering why those were included, because we're supposed to be converting to all electronic benefit and in WIC. So thanks.
Yes, it was a little bit mentioned mostly for to understand that they have been previous identified studies that had commonalities regarding transportation issues or issues in a WIC clinic. So I just wanted to kind of highlight that it was an issue previously mentioned before the pandemic, but as the pandemic developed, it seemed much more evident and needing to give a solution to. So that it was a little bit more of an introduction into the subject.
Great, thank you. Donna, you have your hand raised, I see.
Yeah, I just wanted to congratulate Sophia and that to comment on the fact that Sophia, and who presented yesterday, Kristen?
Let me get my list out.
It was Madeline.
Madeline, yes. Mm-hmm.
Okay, Madeline. Okay, so Sophia and Madeline are our first cohort of our new MHS program. Madeline, I believe, is full-time? Was full-time?
Yes, she was pursuing it full-time, yes.
Right.
So she just started in the fall.
Actually, the first of our online cohort with the MHS and MCH. So I just wanted to congratulate her, and I was unable to attend yesterday. So I just want to congratulate both of them for being in our, inaugural cohort of MHS in our new revised both online and on-site program. So great work.
Wonderful.
I do want to mention, I want to give a shout out to Paris because I did see some comments. I know she was part of the department too. So I was happy to include her in my presentation.
That's so great. You guys, so far, we're getting these alumni to come back to this. Kylie and Paris, I love it. Wonderful. David, you have your hand raised.
My thoughts keep shifting in this conversation. I did want to tie Donna's comment regarding Madeline and Sophia's comment presentation, both superb, but also had this practical consideration with regard to Madeline's talk about tax considerations that underpin this, and Sophia's comments about practical ways by which to deliver services. So the two of them give a slightly different texture to these presentations. So thank you very much. And I just wanted to mention to Sophia, of course, her presentation was not only wonderful, but raised a number of issues. Fresh from our research meeting an hour before this, the issues of looking at population-specific considerations. We see differences in terms of the areas of retention and so on. And I was wondering if that popped up in your work, particularly with infants, where we saw really no substantive, or at least at this moment in analysis, no difference, but continuing differences, trying to explain what's happening at child 1 year and child 2 and 3 year. So I know I'm taking too much time, but I just can't help but draw the parallel between our two MHS students, master students, and also ask you the question. So take it away, Sophia, but I was thinking I couldn't have done a better job. So thank you so much.
Thank you. So a population that really, I think, it was highlighted mostly about it was rural communities in Alaska were mentioned a lot, and just kind of the gaps it may have between numbers or just that keeping track, which that's why the idea of mobile clinics was something that I did want to mention, because in rural communities or in tribal organizations or are affiliated with WIC, it seems to be a prominent issue.
Thank you.
Mm-hmm. Great job again. Wonderful. Thank you so much. And now for our last presenter of the day, Monika Kozlowski. She is an MSPH candidate, and she graduated from the University of Miami with a Bachelor in Business Administration, and she majored in healthcare management and policy as well as marketing. So thank you so much, Monika, and you are welcome to take the virtual platform right now, or podium.
Okay, can you, thank you. Can you see and hear everything okay?
Everything looks great.
Okay, perfect. Thank you so much for that introduction, Dr. Mari. I'm going to be giving you an abbreviated version of my literature review on the vaginal microbiome in preterm birth. Here's an overview of what I'll be covering today. So I will start with a background of preterm birth and the vaginal microbiome, and then a quick brief on my methods, the results, and end with a discussion on the limitations and conclusions. So starting with preterm birth, pregnancy is a critical time of growth and development, with full-term birth occurring around 40 weeks. Preterm birth is one at less than 37 completed weeks gestation. The frequency at which a preterm birth occurs is about 1 in 10 births in the United States. There are multiple pathways that have been indicated for preterm birth, but there's no evidence that any single pathway is a causative pathway to preterm birth, which is cause for concern because it is one of the leading causes of neonatal mortality. There are also some troublesome disparities among preterm birth rates, in which non-Hispanic Black women suffer from a 2 times greater rate of preterm births than non-Hispanic white women. And just as a note, moving forward, the terminology I will be using in the presentation is woman to be congruent with all the studies I researched in which they refer to participants as women. The vaginal microbiome is an evolving microecosystem of microorganisms, and it evolves a lot with time, age, menses, menopause, sexual behaviors, and birth control. Research indicates that a normal microbiome is one dominated by lactobacillus strains. However, regardless of whether lactobacillus organisms are the most dominant strain in the vaginal microbiome, they have beneficial properties such as being bactericidal. I had 2 aims for this literature review. The first was to identify the dysbiosis in microbiomes that may result in preterm birth. And the secondary aim was to identify the differences in the microbiomes between races. My thinking was that if lactobacillus species are dominant in healthy microbiomes and they have protective effects against pathogens and they are bactericidal, then they would also be dominant in the microbiomes of women who deliver a healthy full-term birth. And now shifting into my methods. I started with the general search terms vaginal microbiome preterm, which yielded the most results, 337 results. I then used the database filters to refine to studies published in English, but ex-US studies were included as long as they were available in English, and also filters for humans conducted on female humans, resulting in 263 results. The titles and abstracts of these 263 studies were reviewed to eliminate non-relevant studies, leading to 21 potential studies. Studies that did not include an investigation into lactobacillus species and including preterm birth as an outcome were excluded, resulting in 9 prospective cohort studies and 7 case control studies, which were primarily used to confirm the findings from the prospective cohort studies. And now my results. I'm going to start with a summary of the studies. All 16 studies included in this review were conducted in university hospital settings. 7 prospective cohort studies were conducted solely on low-risk women, or included at least one group with a low pre-existing risk for preterm birth. 2 studies focused on high-risk women. 1 study sample was comprised of majority Asian women, 1 was majority Hispanic women, 2 had samples comprised of solely Black women, and the remaining had majority white participants. 2 of the 9 prospective cohort studies relied on self-collected vaginal swab samples, and the time at which samples were collected during pregnancy did vary among studies, with 3 studies taking samples at multiple time points and the rest relying on a one-time collection. The organisms and specific species that were determined by assays related to RNA or genomic sequencing, and the RNA method is widely used among this type of research, and these tests generally detect all organisms present in a sample. For strains protective against preterm birth, all but one prospective cohort study found lactobacillus to be protective against preterm birth. One study found that full-term birth women had microbiomes that had an abundance of lactobacillus species of over 75%, 83% of which had an abundance of lactobacillus over 98%. The specific strain of lactobacillus, L. crispatus, was a notable strain that was dominant among full-term births among a variety of study populations. One study actually identified a significant protective effect of L. crispatus, in which it was the dominant strain among a group of women identified to be high risk for a preterm birth, but ended up delivering full term. The one study that was a little different did find that lactobacillus was protective, but just wasn't a statistically significant finding, and it was conducted in Japan on high-risk pregnancies, so it definitely was a unique study population, and I will be going into racial differences in a little bit. The case control studies were generally in agreement with these findings as well. And now for the opposite, for the characteristics of or dominant strains in preterm birth cases. So the characteristics of microbiomes among women delivering preterm were as follows. Women with a depleted load of lactobacillus were more likely to deliver early. One study found that no women who delivered preterm had a dominance of L. crispatus, that strain that I mentioned before, compared to L. crispatus being the dominant strain among 36% of women delivering full-term birth. And there actually was a slight inverse relationship between L. crispatus abundance and preterm birth. In terms of specific strains, both ureaplasma and L. annulus appeared to be linked to a preterm birth. L. annulus in one study was present in 85% of preterm births compared to 16% of full-term births. And another study found that 18 women with L. annulus dominated microbiomes delivered prior to 34 weeks. The case control studies found a couple more strains, but most studies did identify ureaplasma and L. annulus as well. Here are the main results for the secondary aim, which was to understand the diversity of the vaginal microbiome by race. Overall, it appears that Black women have the most diverse microbiomes, with Hispanic women having the second most diverse microbiomes, and white women often having only one species of lactobacillus in their microbiomes. Both Black women and Hispanic women had L. annulus in high relative abundance, while white women were often dominated by L. crispatus. Black women also had the lowest abundance of lactobacillus species, less than 50%, especially in comparison to other races for which one lactobacillus species was in abundance and greater than 50% of women. Interestingly, all species of lactobacillus could be found in samples from the microbiomes of both Asian and white women, while the specific strain L. gasseri was undetected in some samples from Black women. And now my discussion. I'm going to start with the limitations. So with any work relying on observational studies, there is no ability to assert causality. And with any literature review, you run the risk of publication bias. 6 of the prospective cohort studies had a small sample size, and 2 of the prospective cohort studies and 4 of the case control studies relied on self-collected vaginal swabs, but research indicates that there is no significant difference between self-collected vaginal swabs and medical professional samples. As I mentioned, there was variability in when samples were taken across some studies, and in one study, Blostein et al., the samples were taken at multiple time points, and the results actually reversed, in that prior to 12 weeks, preterm birth cases had a reduced odds of having a lactobacillus dominant microbiome, while at 12 to 16 weeks, preterm birth cases had an increased odds of having a lactobacillus dominant microbiome. So, and all this just really illustrates the concept of how dynamic the microbiome is, even during the span of pregnancy. Bless you, I think someone just sneezed. I completed this research with 3 main takeaways. The first being that lactobacillus appears to be protective against preterm birth, but the species varies by race, with L. crispatus being the most dominant strain among white women, and L. annulus being dominant among Black and Hispanic women. Secondly, there are some strains that appear to potentially trigger preterm birth, and that is ureaplasma and L. annulus for white women. And lastly, Black women appear to naturally have a more diverse microbiome than white women. And this is important for research and clinical purposes so as not to confuse the more diverse and unique strains among varying races as dysbiosis. In my paper, I did do a short review on the literature of probiotics as an intervention to prevent preterm birth, but that is outside the scope of this presentation. But it is a crucial area of future research, especially in using the strains that are beneficial to each respective race as an intervention in pregnancy. I would like to thank everyone in my cohort, all my professors, my family, but especially my amazing advisor, Donna Strabino, for being nothing short of amazing over the past 2 years and being absolutely crucial to my success in completing this project. And now I'm open to your questions. Thank you so much.
Great job, Monica. That was so interesting. So yes, let's turn it over to questions. And again, I will just select whoever I see first. And right away, I see Teresa's hand raised. So Teresa, you have the floor.
Yeah, great job, Monica. So I guess I'm thinking of the Nature article that found the microbiome of the placenta was very similar to the microbiome of the operating room. And I was wondering if in any of the articles you came across, there's sort of a standard with collecting samples from the clinic or the lab to ensure that there's not contamination that's impacting the results.
Yeah, that's really interesting. I actually did not come across that in any of the articles that I was looking at, but that's definitely important. And I did actually come across something kind of similar where if you were using like a vaginal pessary for probiotics, then you have the risk of introducing other contaminants that's on whoever's inserting the pessary. But that's definitely a really interesting area to look into.
Thanks.
Great, thank you. Terry, I see your hand.
Sorry, was unmuting. I'm just interested in the practical use of this. How might providers access this information? Like, how might providers tell women this and then help with prevention of preterm birth? If we identify these microbes, like, hey, like, you know, I think about all the screener things or all the like things that give providers kind of a call, like a cause for pause. Mm-hmm. How could this be implemented or integrated into normal practice for pregnant people?
Yeah, so in my research, it definitely seems that if you don't have a lactobacillus dominated microbiome, then you may have an increased risk for preterm birth. But I do think it's important to understand, again, I don't think we can make a blanket statement to all women. Like, we need to consider the racial differences. And I think that hopefully moving forward, we can see an intervention because we want to be able to see, okay, if we run a test from a vaginal swab and we see that you do have a lactobacillus depleted microbiome, we want to be able to do something about it. And if it's, especially if it's related to a dysbiosis or bacteria in your vaginal microbiome. So hopefully there is some work that I did see like on clinicaltrials.gov where they are doing trials on like probiotics to use in your vagina during pregnancy that appear to be safe, but if they're effective, that is definitely still questionable. But that's where I would like to see this go.
Mm-hmm. Great. I see some questions in the chat, so I'm going to turn it to those. So Sally says, Monica, these results are really interesting. What factors are related to the microbiome composition? Anything like STIs, diet, etc.? Could those factors possibly explain / confound the relationship you saw?
Yes, I love that question because, again, as I said, the vaginal microbiome is so dynamic and so many things affect it. It's kind of crazy to think about. So yes, diet, and actually they found diabetes and high blood sugar could alter your vaginal microbiome in terms of like diet and lifestyle. Women who have sex with women is a behavioral one that was found to be linked to dysbiosis in your increased risk of infection. Douching, if you're allergic to any lubricants or any of the ingredients in condoms, so that could be something that you physically come into contact with, disrupting your microbiome. I'm trying to think of any others. There's a long list of things. So the answer is yes. A variety of these things play a part, and that did come into the discussion on why we also see these racial differences and what factors we could be missing in that discussion.
Mm-hmm. Great. And then Cynthia says, great work, Monica. Do clinical guidelines inform decisions about analyzing microbiome data? And if so, for what groups? Or is it too early for our understanding?
Yeah, I think it's too early. I didn't come across any clinical guidelines on it, unfortunately. And yeah, there's no concrete clinical guidelines saying, again, that a dysbiosis, or like, yes, there is the research that says potentially depleted lactobacillus can lead to preterm birth, but there is no concrete clinical guideline on it, unfortunately.
Mm-hmm. Okay. Last question by Susan. Great job, Monica. Do you know how the microbiome changes over the life course? There's a lot of research about how the maternal microbiome impacts infant microbiome, especially related to breastfeeding.
Yes, thank you for that question. So there was the one study, Blosina et al., that had 2 different time points of collection. So they found within the same woman and the same pregnancy, her lactobacillus loads and overall her microbiome changed throughout the same pregnancy. And so we do know that once you start menses, your microbiome changes, same with menopause, sexual intercourse, if you're introducing different sexual partners, it changes. And going back to the mother-fetal connection, there is some research, it's mostly concentrated with the gut microbiome from mom to fetus, but they do hypothesize that during delivery, if you're having a vaginal delivery, there is a transfer potentially, but potentially also prior to delivery through the amniotic fluid. So it's definitely a very interesting area of research. I hope I answered that question completely. Let me see. Yeah, did I do a good job? Okay.
Okay, thumbs up. So thank you so much. Wonderful job. We're going to end here a little bit early, but we do have more presentations around the corner. So just to let you know that next Tuesday at noon, we'll be starting our 3rd round of presentations. So make sure you are available for that. But with that, I want to just give everyone another round of just praise. It was just, I learned so much today, and I want to just give all 3 of you a just great round of applause. I wish, this is one thing we miss when we're not in person is the applause. So you're getting lots of praise there if you can look at the emojis. So thank you all so much. Good to see you. And we will see you next Tuesday. Take care, everyone.